Okay. First, Katelin, earlier this year when she was giving a basically an overview of the pharmaceutical market here in New Mexico, up in Taos. And based on the presentation she gave that day, I've invited her to meet with you today. So hopefully you'll get a lot out of this and we'll have some good questions at the end. So Katelin, it's all yours. Thank you.
Thank you all, and thanks for letting me join you for lunch today. Do wish I could be there in person. It's always a little bit strange to present via Zoom to a live audience, and I'd much rather be there chatting with you all after this presentation. But thank you again, and thank you to Greg and New Mexico Bio for all of the work that I know went into this event today. My name is Katelin Lucariello. I'm the Senior Director of State Policy for the Pharmaceutical Research and Manufacturers of America, or PhRMA. Prior to joining PhRMA, I was in state policy consulting for over a decade. So state policy is really just like the love of my life, which tells you, how little fun I probably have on my weekends. So I'd like to start off by talking just a little bit about PhRMA, the organization that I represent. And PhRMA represents 33 of the country's leading biopharmaceutical research and manufacturing companies. And as part of that representation, our responsibility is to advocate on behalf of policies that support the incredible innovation and research that comes out of this industry, and also policies that help patients benefit from that innovation, so that help patients better access and afford their medicines. So today I do want to spend a good deal of my time focusing on that second piece. But before I do jump into that, I think it's really important to frame discussions around policy, and really why there's never been more of a need for policies that not only address patient affordability, but also balance the industry innovation that we have today. It's kind of great to be talking to this room. It's not a venue that I'm usually in. I'm usually talking to legislators or folks that really are not involved in the industry. So I think it's really kind of no secret to anyone in this room that we work for a really awesome industry that is at the center of really a new era of medicine breakthroughs. And what I mean by that is you all are really transforming how we attack the cause of the disease, not just addressing symptoms, creating treatments that are more individualized, and really moving us out of science fiction into reality. And while many of these therapies that are being developed today are expensive, they're also highly effective, and they're offsetting much larger costs to our healthcare system. And it really is for that reason that it's important that us folks at PhRMA work to ensure a policy framework and promote policies that are adapting and evolving to match the pace of innovation in this industry. At the same time that we have this incredible innovation going on, we are facing more threats to the industry in the form of policies than we ever have before. So some of those in the states look like price controls that seem like price negotiations, reference pricing that tie prices from other countries that are government negotiated and often well below market value to prices in our countries, prescription drug affordability boards, which I think we're likely to see here in New Mexico next session, that cap the price of medicines in a state. All of those policies are really concerning because of their impact on investment into new therapies, because they can cause companies like yours to reprioritize development of certain therapies, and because they really have, life-altering consequences for patients that are waiting on medicine breakthroughs. And the reality is that all of these policies are kind of underpinned by just an exaggerated narrative and a very politicized narrative of skyrocketing drug prices. I think we are pretty used to hearing that in the industry. In reality, I want to kind of set the record straight on that narrative. Overall medicine spending has for the past several years and continues to be a very small but stable share of overall healthcare spending. It rests just around 14% of total healthcare spending in the United States. And that is a trend that we really expect to see continue, even as these novel breakthrough therapies that you're all working on and developing come to market. And what we've seen in terms of reports out there that say brand medicine prices are increasing, they're skyrocketing, they're out of control, is often those reports are focusing on a very select number of drugs to support that narrative. When we look at prices as a whole, after accounting for rebates, which we can chat about here a bit in a second, the net price of brand medicines has and is expected to continue again to stay flat and has for the past 5 years. I very recently, actually just in the past week, maybe you've seen these reports going around on pharma's hikes on drug prices on 350 medicines at the start of the year, or big pharma celebrating the new year with price hikes on 350 medicines, or new year, new price increases for pharma on 350 medicines. You get the idea. One really important detail that's not captured in that headline that you kind of learn as you read a few sentences into the article is that even as an industry, when we're contending with inflation, when we're contending with new supply chain constraints, and seeing higher manufacturing costs, the increases on those 350 prescription medicines were still well below the rate of inflation this year. And that is really consistent with what we've seen in reporting from the Bureau of Labor and Statistics, is in the last year, inflation for medicines has risen much lower than inflation overall. I do want to quickly level set, because I think sometimes when I present this information, it is counter to what a lot of folks are hearing and what a lot of patients are feeling. And so I don't present this information to say that patients are not experiencing affordability issues with prescription medicines. They are. And if they weren't, I wouldn't be presenting to legislative committees and talking to legislators about these issues, and I wouldn't be here today to talk about focusing on policies that help patients better afford their medicines. It's also not to say that manufacturers have no role in drug pricing. I think we all know, we all do, we set the list price of medicines, but it is to say that policies that signal out manufacturers as kind of solely responsible for the price that a patient's paying is an oversimplification. And it is often leading to policies being introduced and passed that overlook the role of many others, including PBMs, insurers, hospitals, wholesalers, and the role that they play in that drug price equation. There are many roadblocks in the marketplace to lowering the price that patients pay for a medicine and having that align with some of the trends that I just talked about. One of those things is the growing influence of pharmacy benefit managers in the marketplace. And I think you all likely know, I think I'm an audience with friends here that know PBMs administer pharmaceutical benefits on behalf of health plans. They manage drug utilization. they create formularies, and they are responsible for negotiating discounts called rebates with manufacturers. And 10 years ago, we didn't hear a lot about PBMs, but PBMs really have started to have a growing influence in the supply chain, and their role has kind of moved beyond that static role that I just talked about. Now the volume of of claims handled by the 3 largest PBMs is around 80%. The percentage of prescription drug claims handled by the 6 largest is around 96%. That is giving them absolutely huge leverage in negotiations with manufacturers and a really considerable influence on access to medicines and coverage of medicines for patients. And one place that you really see the influence of PBMs is in those negotiations on rebates with manufacturers. So today, the price paid by a PBM, insurer, or other entities for a medicine, the net price, is on average 49% lower than the list price. They're effectively getting a 49% discount on average off of the list price. And obviously this is an average, so we see it being even higher in some therapeutic areas. Insulin is an excellent example of that relationship between list and net price, where the net price after rebates and discounts can be around 80% lower than the list price of a medicine. You also see just the growing influence of PBM leverage in the sheer quantity of rebates that they are negotiating on a yearly basis. So in 2012 was around 74 billion. That has more than tripled to this year. I think we're getting close to $300 billion in negotiated rebates and discounts. And truly their leverage is only increasing. And with kind of this increasing leverage, we're really seeing a shift in where medicine spending is going. So now imagine your medicine dollar. Every around over 50 cents at this point, actually, this slide is a little bit old, but over 50 cents of every dollar spent on a prescription medicine is now going to a middleman, not to the manufacturer that's making the medicine. So this is a substantial change in this trend over time. And if you could continue this chart to 2022 and 2023, what you see as it starts to be a lower share for manufacturers being retained, and other stakeholders are retaining a higher and higher share. So kind of the trend here continues. One of the reasons why we see increased leverage and increased influence of PBMs in the marketplace today is because there's been a tremendous amount of vertical integration among that industry over the past decade. So where PBMs were once limited to administering pharmaceutical benefits and negotiating on behalf of health plans, they now own the health plan that provides the benefits, the pharmacy that dispenses the medicines, and are even moving into the space where they're purchasing provider groups that are prescribing those medicines. And this, again, just really changes both the scope and the scale of what these companies do. And looking at solely at PBMs is not really consistent anymore with what their relationships actually are. So one question that I often get, and I actually think it's a great question, is why do manufacturers even negotiate with PBMs? And I mean, one of the reasons is because they're covering 96% of prescription drug claims dispensed. It's actually pretty simple. And we need to negotiate with PBMs because they're determining if our medicines are placed on formulary. So we're a little bit hamstrung, really. And one of just kind of the misalignments that we see overall is that PBM's compensation has become tied to the rebates that they're receiving from our manufacturers. And this really, it creates a number of misalignments because they then have incentives to prefer higher list price medicines with large rebates over lower list price medicines. And for that reason, will exclude lower list price versions of medicines from their formularies in exchange for higher price versions. We've also seen some behavior where PBMs will write into contracts with manufacturers that if manufacturers lower their list prices, they still need to retain the same payment of the same rebates that they were paying the PBMs. So it really is kind of a hardball tactics, tough situation. And growing influence, growing formulary exclusions. So PBMs are increasingly removing drugs from formulary, sometimes generics or biosimilars, in favor of those higher priced medicines with those higher rebates. Over 1,100 drugs were excluded from formulary last year, a substantial amount. And it's bad news for manufacturers because when PBMs are controlling so much of the market, not having your drug on formulary, having your drug subject to a utilization management protocol like step therapy or prior authorization or quantity fills, all has implications for patients being able to access your medicine. So really, these are all tactics that are greatly helping PBMs increase their profits over time, but they're leading to higher out-of-pocket costs and really just less access overall for patients. So I mentioned earlier that PBMs are paying about 49% less than the list price of the medicine. Another question I often get when I bring up that statistic is, then why don't patients that are insured feel the impact of those discounts on prescription drugs? And really the reason is they're not benefiting from those discounts. So instead of those rebate dollars going directly to the patients taking the rebated medicines, they're being either retained by the insurer PBM, or they're being spread across all enrollees to lower premiums. They don't have a really significant impact on premiums, which I'll talk about when we get to policies here a little bit in a second. But they would have a really significant impact if they were actually used to lower the price that patients were paying for their medicines. Another reason why patients aren't feeling the benefit of some of these trends and the impact of lower net prices is changes in benefit design that we've seen in recent decades. Benefit design used to have a lot of static, kind of predictable copays. Now we see a much broader use of coinsurance, which requires you to pay based on a percentage of the price of a medicine, and increasingly high deductibles. Those shifts are really important because what those plan designs do is require patients to pay the list price of a medicine. So not the negotiated price that the PBM and insurer is paying. And it sounds backwards, it is. It's really specific to prescription drug benefits. So if you were paying for an in-network doctor or you had an in-network hospital visit, your bill would be based on the plan's negotiated rates. So it's not the case with prescription drug benefits. It ends up being really particularly important in places like New Mexico because New Mexicans are facing the highest annual deductibles relative to income of any state. That means that they're going to face much higher out-of-pocket costs because they're being exposed to the list price when they're in their deductible period. So getting down to some of the policies and some of the things that the industry is doing to help lower the prices that patients pay for their medicines. One of the most direct ways that we as an industry lower out-of-pocket costs for medicines is by offering patient assistance for medicines on the market. These are a very important source, especially today, as we're seeing shifting and changing of plan design, to helping patients pay for their deductible or get through their high cost sharing. Just for example, in 2019, patients taking MS medicines for multiple sclerosis, saved an average of $2,200 using manufacturer patient assistance programs. Patients with HIV saved an average of $1,600. And when you have a $2,000 or $3,000 deductible or $1,500 in out-of-pocket costs, having that coverage is substantially beneficial toward helping you get through those deductible periods or helping you afford those out-of-pocket costs. Manufacturers really augmented their patient assistance programs during COVID, and we've seen that same level kind of maintained as we're moving into post-COVID world, we'll say. So our manufacturers offer over 950 patient assistance programs today. One of the things that we often hear from patients, from caregivers, from providers is that these programs are hard to find. They're difficult to access. They require a lot of information. Their concerns were heard. PhRMA launched the medicine assistance tool several years ago now to make it easier for patients or their caregivers or their providers to have a centralized location where they could find information about these programs, find information about the various savings cards offered by manufacturers, and then also information about costs of their prescription medicines and additional resources to help them afford other sorts of healthcare costs. I have actually used the medicine assistance tool before. It's pretty easy to use. You go on, you enter the medicines that you need help accessing, some basic patient information, which is limited to kind of where you're located, what your insurance coverage is, or if you're uninsured, your age, your income, and Matt will provide a list of programs that you can qualify for. So it's a great tool to helping connect patients to some of the really significant programs that manufacturers are offering to help them draw down on their prescription drug costs. So I know there was a point in that part of my presentation where you started thinking, I thought we were here to talk about policies to help patients pay less. And instead we're spending an awful lot of time on pricing dynamics. And you're totally right, we did. But I think this background is a really important foundation to kind of understanding how the policy solutions that we'll talk about here in a moment offer immediate relief for patients struggling to afford their medicines. I'm sorry if everyone just saw that Adobe update pop up. Been putting it off for a while. So I operate in state policy, as I said earlier. A lot of these are state policy solutions, or policies that you maybe have seen or could see at the state level to help patients pay less for their medicines. And you'll see how some of that spiel that I just gave earlier ties into a lot of these policies as well. So the first policy that we support at PhRMA and could see at the state level is PBM compensation reform, or delinking PBM compensation from list price. I know that sounds just a little bit complicated, but really what we're talking about when we talk about PBM compensation reform is requiring that PBM compensation no longer be tied to the list price of a medicine. and to instead require that their compensation be based off of flat fees and the services that they're actually providing. So as you can imagine, this would really go a long way to addressing some of those misaligned incentives that we talked about that are driving up list prices, that mean that lower list price medicines are being excluded from formularies, and that are impacting contracts with manufacturers and their ability to offer drugs at a lower list price. So pretty simple explanation on that one. I will take questions at the end and happy to chat a little bit more about each of these. I think we could really see, well, we have seen a variety of flavors of PBM regulation in the states. And I imagine that that is only going to increase since the Federal Trade Commission has now launched an inquiry into that industry and a number of their practices. We, I think, have also seen a substantial amount of legislation in this area on spread pricing with PBMs. And that is when PBMs charge health plans or payers more for a prescription medicine than they're reimbursing a pharmacy. And then they keep that difference, that spread. There is a rather kind of famous example of this now in Ohio, where policymakers launched an investigation into spread pricing practices for PBMs. And what they found was the PBM that was administering benefits on behalf of their Medicaid program had used spread pricing to make over $200 million more per year from the state than they were reimbursing pharmacies. That has huge implications, as you can all imagine, for state spending on prescription medicines and for spending on prescription medicines by taxpayers. So we at PhRMA, we have kind of like cute names for a lot of these policies, but I'll talk through what each of these policies is that makes up our proactive platform of policies. So Share the Savings is another policy that essentially addresses some of the misaligned incentives in the system. As I said, rebates and discounts are largely not being shared with individuals to lower the price of their medicines at the pharmacy counter. This would require PBMs and health plans to do so. And I also mentioned earlier that sometimes PBMs and health plans are using rebates to lower premium costs for all. There's a question there of what the premium impact would be for this type of policy. Milliman did take a look at that, and what they found was really substantial savings for patients taking rebated medicines. They could save up to $1,000 annually, but really minimal impacts for premiums because you're spreading those rebate dollars so thinly across so many enrollees. And so the premium impact was around less than 1%. I think it's also worth mentioning that this is a policy we've seen introduced in several states. We saw it passed in West Virginia a couple of years ago, and polls in some of those states showed that if patients were faced with kind of that trade-off, slightly higher premiums and substantial savings on your medicines or your out-of-pocket costs, there was broad support for making that trade-off. And I think it really is getting at making insurance work more like insurance should work. The sick should not be subsidizing the healthy people's insurance premiums. So Make Coupons Count, another one of our cute policy names, really is about banning accumulator adjustment programs. So we've seen 16 states, New York's governor just signed this policy into law, 16 states that have passed laws to ban accumulator adjustment programs. It's a mouthful. I call them AAPs, but really essentially accumulator adjustment programs, or AAPs, are policies that are being implemented excuse me, by insurers as part of their health plan's benefit design. And what they do is they stop that assistance from applying towards a patient's deductible or their annual out-of-pocket limit, as I mentioned earlier, it kind of traditionally has. So what does that mean for patients? It means that they end up paying possibly thousands of dollars more each year on their medicines. It means that the plans get to double dip. They get the full value of that patient assistance, and then they get paid again by the patient. So they're paid by the manufacturer, and then that doesn't count towards patients' out-of-pocket costs, then they get paid again by the patient. It also means for patients that they can end up with a real surprise because just like accumulator adjustment program is hard to say, it's pretty hard to understand for a typical person what that means when they see that a copay accumulator has been added to their policy. And it's hard for them to determine what that practice will mean for their out-of-pocket costs when they get notice from their insurer that that's now part of their plan. On to the next, lower cost sharing options. So the idea with this policy is really to require all plans or a percentage of plans to offer a copay only cost sharing for prescription drug or copay only cost structure for prescription drugs. So that means no deductible and no co-insurance. So none of those plan designs that subject them to the list price of a medicine. Instead, just kind of set predictable copays. And then it takes it a step further. It says that the highest copay needs to be limited to 1/12 of a health plan's out-of-pocket maximum. So if your out-of-pocket maximum for the year is $1,200, instead of being subject to that upfront January 1, you know your highest allowable copay per month is going to be $100, 1/12 of that amount. I think we can all imagine that creates just a substantial amount of predictability for patients. And then it allows them to budget for what their medicine costs are going to be when they have that information up front. So they're very much less likely to walk away from the pharmacy counter because they got a surprise when they came to the pharmacy counter, not realizing what their medicine costs were going to be and not being able to make heads or tails of their benefits. This has had limited uptake, but we did see a law passed last year. It was actually a regulation that was codified into statute in Colorado, my home state, that said that 25% of plans needed to offer this lower cost sharing structure. And that's great because when somebody is going to select their plan for the year, if they know that they have a number of medicines that they need, number of prescriptions that they need, they can pick one of these plans and again, just have that predictability of what their co-payments are going to be. Cover medicines from day one is just a version of the option that we just talked about. It doesn't speak to if a plan can actually have co-pays or co-insurance. It just says no deductible from day one. So if you go to your pharmacy on January 1st, you're not faced with your deductible, you're faced with your copay. So you have to pay $5 or $10 or $15 or $25, whatever your set copay is. And then finally, we have hard dollar cost sharing caps. I think this is probably the policy that most people are familiar with in the States. We've seen a number of forms of this policy as it pertains to insulin caps. So there's about 24 states. I think New Mexico was actually one of the very first states that implemented a cap on what patients could pay for their insulin. But the reality is, like, this doesn't have to be limited to one therapeutic category. There could be monthly or annual caps on all prescription medicines. There could be caps on just specialty drugs, or you could do it by therapeutic category and chip away that way. really what we see is lower adoption of having a broad copay cap legislation in the states, but we do see adoption of it. So there's 9 to 10 states that have some form of broader copay cap outside of the insulin caps that we commonly see. So Louisiana has a $150 cap on specialty drugs. Maine has an annual cap of $3,500. You never pay more than $3,500 annually for your prescription medicines in total. Really, we should see more of these policies in the states with how popular these policies have been for insulin. So that's something that we will support and continue to advocate for moving into the next sessions. I know that's a lot of information to pack into a half hour here. And so for those of you that have kind of full stomachs and maybe, you know, their attention kind of went another direction during the time I've been talking, I think just the big kind of takeaway from my presentation today is there's a lot of temporary state policy fixes out there to lower prescription drug costs for patients. But many of them are based on political rhetoric. Many are destabilizing for this incredible industry. And some of them are just counterproductive because they're not getting at a number of the real issues that are driving up costs for patients. And then on the opposite side of the same coin, you know, there's good news out there because there's a number of policies that are market-based and could go a long way towards fixing misalignment in the market, could go a long way toward directly lowering out-of-pocket costs, and could get us back to helping and make insurance work how it is supposed to. So I will stop there. Thank you all for hanging in with me. I would love to take questions. I'm curious what you all are thinking. So thank you very much and look forward to being able to chat with you a little bit here.
Katelin, I'll kick it off with the first question. And basically, our legislative session starts next week. And I'm wondering from your perspective, if you've heard anything on the grapevine in terms of legislative bills that we should be paying attention to.
Yeah, it's a great question. And I'm looking forward to the legislative session starting, and I'm looking forward to being in New Mexico for this legislative session. So first of all, if you see me out there, please say hello and introduce yourself. I'd love to get to know some of you better. I think we are expecting to see a prescription drug affordability board bill in the state. What form that will take is questionable. A lot of these bills, as I mentioned at the outset of this presentation, have price controls in them for prescription drugs that would effectively cap the price paid for prescription medicines in the state. States don't have the ability to impact list prices of medicines or impact negotiations in the supply chain that are happening outside of the state. So typically those caps are limited to purchases and reimbursements of prescription medicines in the states. But we kind of have seen just a variety of those bills. Some of them have price caps in them. Some of them establish a board to look at drug prices, but don't actually prescribe price caps or what the price control mechanism would be. So I think we're certainly looking out for that bill. We're just not sure what form it will take. Very recently, the governor appointed a prescription drug task force, and there were some really interesting recommendations that came out of that task force. A lot of them were really focused on PBM's roles and some of the misalignments in the supply chain that I talked about with you today. And so it was really refreshing and encouraging to see some of the recommendations in that report that were looking in that direction. Now, if that becomes legislation or not next session, I think it still remains to be seen. We haven't heard what's going to be on the governor's call, but it would be a really great thing for changing the narrative in the state and actually passing some policies that lower out-of-pocket costs for patients immediately if some of the recommendations from that task force were picked up in policy.
A follow-up question for you. In terms of your, I guess, healthcare partners here in New Mexico, who basically are you working with besides NMBio and maybe some in the healthcare sector that you try to work with?
Yeah, you know, we have a number of relationships with patient groups, with provider groups, particularly when we're looking at the impact of some of this price cap legislation. And when we're talking about a prescription drug affordability board and that impacting potentially purchases and reimbursements of medicines in the state, we're engaging pharmacies that are going to be affected, potentially be affected by that, providers that are going to potentially be affected by that. So those are some of the places where we've looked to establish more significant relationships. And then it's, I think, always extremely helpful, especially on these state bills, to have some of the local biopharma companies come out and to, you know, testify, to talk to legislators about what the impact can be on industry. And so to the extent that we can further relationships with local biopharma companies, that's a place that we're looking to expand to, because that voice is really well received when we're in conversations on those topics with legislators.
Well, one of the arguments is that drug pricing really can impact startups and hurt their chances for going forward. Can you talk maybe a minute or two about that?
Yeah, and you know, I'm on the brand medicine side, and as you saw, PhRMA's membership has, you know, some really big companies. But in Colorado, for example, one of the folks that we saw have just to play a really big role and really have an impact on legislators when we were facing a prescription drug affordability board bill was a CEO that came forward and said, listen, I would love to offer this lower price version of a medicine. I can't get it on formulary. And so not only in the pricing equation, but also talking about some of the struggles with negotiating with supply chain, with actors in the supply chain, has enlightened legislators a lot toward, you know, what these local groups are facing. Local voices make a huge difference. They really do. Sometimes folks are tired of hearing from me. I'm big pharma, and I don't carry the message nearly as well about the significant risk that you all are taking, about the uphill battle that you all have when you're bringing a drug to market, and how these policies directly impact folks. Another place where we've seen voices of companies being really helpful is at the federal level, which I don't engage in a lot, but with the IRA. You know, the IRA certainly has some things in it that we support. It has an out-of-pocket caps. It smooths costs over the year, that 1/12 of maximum out-of-pocket costs. It has a similar structure to that. But ultimately, we've heard from many companies that it's made them reassess their portfolios, that they've had to reprioritize drugs in development, that they've had to stop research on certain medicines in their pipeline as a result. And to the extent that that message is local when we're working in state policy, it's really helpful.
Thank you. Any questions? Mariah?
Hi there. I have a question which may sound a little bit naive, but what how does a pharmaceutical company determine the list price for a drug or pharmaceutical? What goes into that equation?
Yeah, not naive at all. A question that I get asked often. And the reality is it's different for every company. The price of a medicine and how it's determined really depends mostly on a range of factors, and how they're weighted by companies is very different. And I don't, because I represent, the whole trade, I don't have a lot of line of sight into individual companies, but kind of that range of factors tends to be how much market competition a medicine is facing, the clinical benefits of the medicine over its competitors, or if it's unique, what kind of unmet medical need that medicine has, the size of the patient population that is going to have access to that medicine, and then, of course, the investment that's been required to bring a medicine to market, and the cost of previous failures is also something that's taken into account. And then, honestly, affordability is taken into account. I think that's something that surprises a lot of people, maybe not in this industry or in this group today, but if patients can't afford medicines, they can't get access to them. I mean, if they're priced so high that there's an affordability problem, that's an issue for access. And so, again, the importance of those factors ranges, but all of those things are things that are being considered when a company is looking to set a list price.
Okay, greatly appreciated. Thank you for your time. Okay.
Thank you all so very much. It's great to be there, and hope to get to meet a good number of you very soon. Thanks, Greg.
Thank you. Let's see what the schedule says. Hold on. All right, before we do our next presentation, I want to bring up Lannell's representative to give a short overview in terms of their work.